Good morning, everybody. Today I am starting a very important topic for an anesthesiologist, that is the weaning from ventilators. A 50-year-old smoker, a known case of COPD with dilated cardiomyopathy, was admitted to the intensive care unit ICU with altered sensorium and acute respiratory distress. His arterial blood gases showed severe hypoxemia and acute respiratory acidosis. He was intubated and put on controlled ventilation, CME. He improved in 2 days. Spontaneous breathing trial, that is SBT, was tried and the patient was extubated after successful SBT. After 5 hours, the patient again developed severe respiratory distress and had to be re-intubated. He failed several trials of SBT. Tracheostomy was done on the 9th day of ventilation. Weaning from mechanical ventilation means the transition from total ventilatory support to spontaneous breathing. It is usually a rapid and smooth process in most of the patients. However, this can become a progressive and prolonged process in 20 to 25% of the cases. These patients require a systematic approach for successful liberation from the ventilator. It should be started early once the patient fulfills the criteria for weaning. This weaning has 2 components: liberation from the ventilator and extubation. The sooner the patient is liberated from the ventilator, the lesser are the chances of ventilator-associated pneumonias, ventilator-induced lung injury, decreased ICU length of stay, and overall reduced mortality. Step 1. Identify the readiness for weaning. Weaning should never be hurried, as it can be successful only when the patient is ready both physically and mentally. At the same time, it should also not be delayed, as it is associated with complications. Any patient on MV, that is mechanical ventilation, should be considered for weaning if he or she fulfills the readiness criteria as mentioned below. Number 1. Prerequisites for readiness criteria. The underlying reason for mechanical ventilation has been stabilized and the patient is improving. The patient is hemodynamically stable on minimal to no pressures, that is vasopressors. Oxygenation is adequate. As for example, PaO2 over FiO2 more than 200. PEEP is less than 5 to 8 centimeter of water. FiO2 is less than 0.5. The patient is able to initiate spontaneous inspiratory efforts. Based on these criteria, the patient should be afebrile, there is temperature less than 38 degrees centigrade, have stable metabolic status, that is pH is more than or equal to 7.25, adequate hemoglobin, as for example hemoglobin more than 8 to 10 gram per deciliter, and adequate mentation, that is arousable, and Glasgow Coma Scale is more than 13. Understand the predictors of successful weaning. The predictors of successful weaning have been designed from physiologic parameters to help the decision-making process. However, none of the tests alone are particularly powerful, and clinical judgment is of paramount importance. Rapid Shallow Breathing Index RSBI is assessed by putting patient on TPs for 2 minutes. F, that is frequency, over VT, that is tidal volume in liters, less than 100 is predictor of successful weaning. The threshold of 100 is not binding and can be relaxed by 10 to 20 in patients with endotracheal tube size less than 7 and in women. Minute ventilation less than 10 liters per minute. Respiratory rate less than 35 breaths per minute. Maximum inspiratory pressure more negative than minus 30 centimeter of water. Prepare for weaning, that is step 2. Stop continuous infusion of sedation daily to awaken the patient to do the spontaneous awakening trial, that is SAT. Communicate with patient, explain the procedure and calm them. Record the baseline parameters and keep flow sheet at the patient's bedside. Keep a calm, peaceful environment and have the nurse or physician remain at the bedside to offer encouragement and support. If the patient fails the SAT, that is spontaneous awakening trial, restart the sedation on half of the previous dose. If the patient passes the SAT after stopping the sedation, assess the patient for spontaneous breathing trial, that is SBT, based on the prerequisites criteria mentioned in step 1. Clinical criteria of SAT failure: anxiety, agitation or pain, respiratory rate more than 35 per minute, SpO2 is less than 88%, respiratory distress and acute cardiac arrhythmia. Step 3. that is, do the spontaneous breathing trial, that is SBT. Whenever possible, position the patient upright in the bed. Thoroughly suction the endotracheal tubes and ensure the patency. Any of the following modes can be chosen for SBT. Number 1, T-piece. Patients are disconnected from the ventilator and made to breathe humidified oxygen air mixture through a T-piece connected to the endotracheal or tracheostomy tube for 30 to 120 minutes. Increased respiratory load is offered by the endotracheal tube. Dyspnea and fatigue should be carefully avoided. Pressure support. The pressure support level is to be gradually reduced, titrated to respiratory rate and the patient's comfort. A level of 6 to 8 centimeter of water pressure support is considered to overcome the tube resistance. Put the patient on pressure support of 6 to 8 centimeter of water and PEEP of 4 centimeter of water. Failure of SBT. Objective measurements. PaO2 less than or equal to 50 to 60 millimeter of mercury on FiO2 more than or equal to 0.5 or SaO2 less than or equal to 90%. PaCO2 more than 50 millimeter of mercury or an increase in the PaCO2, that is more than 8 millimeter of mercury. pH less than 7.32 or a decrease in pH more than 0.07 pH unit. Rapid shallow breathing index is more than 105. Respiratory rate is more than 35 or an increase of more than 50%. Heart rate is more than 140 or an increase of more than 20%. Systolic blood pressure more than 180 or an increase of more than 20%. Systolic blood pressure less than 90. Cardiac arrhythmias. Now, what are the subjective clinical assessment? That is agitation and anxiety, depressed mental status, diaphoresis, cyanosis, evidence of increasing effort that is shown in increased accessory muscle activity, facial signs of distress and dyspnea. We come to the end of this part of the lecture. We will start again next day. Thank you.